OncoPlex platform helps me as a clinician. I believe it will help oncologists in general fully understand the biology that underlies a particular patient's cancer. And more importantly, how to link that biology to making rational treatment decisions for that particular patient and really bring the whole concept of personalized medicine to the clinic in a very meaningful way.
Now, there's another important point about the OncoPlex diagnostic profile. At this time, we are running approximately 20 different protein biomarkers, but this can be expanded to 100 or more. And unlike immunohistochemistry, where as you expand the number of biomarkers one is looking at, the OncoPlex diagnostic profile does not need more tissue. It's still 2 slides of paraffin-embedded tissue.
The advantage of using the OncoPlex Diagnostics protein panel over other diagnostics technologies are numerous. One is that the majority of those tests or biomarker assays are low throughput, where they require a lot of tissue to assay the tumor for a number of different molecular events. Immunohistochemistry requires a 4-micron section for every protein that is done. Similarly, FISH requires the same amount of tissue for every single gene that is assessed. Whereas with the multiplex assay with 10 microns, we can quantify up to 20 proteins very quickly and get all of that information at once.
We are now incorporating next generation sequencing genomics into the profile. And I think the combination of having proteomic data at the same time from the same specimen with genomic data can be extraordinarily informative. So for example, if we knew that a patient has an EGFR mutated tumor, of course, we would treat them with a drug like erlotinib. But what if they don't respond to erlotinib? There are many reasons for potential erlotinib resistance, including other mutations in the EGFR kinase. But isn't it possible that one reason is that the EGFR protein is not expressed? So even if you have the mutation, but do not make the protein, you are not likely to respond. Most chemotherapy trials are based on empiric data that are given to patients that are not generally stratified based on biomarkers that potentially could predict their response to various chemotherapies.
The OncoPlex DX panel I use initially when the patient is diagnosed. I get the assay and I can have a quick overview of what's going on in that patient's tumor. We can see the proteomics with the number of proteins and their quantification, and we can see the genomics from the same lysates. From that information, we know that even though we can detect one particular molecular aberration, patients often have numerous things going on in their tumor. And on average, genomically, there are about 3 or 4 events. When you add and couple the protein that's going on, there are a number of things going on. And so we have to set a prioritization scheme. So I use this to see what's going on in the tumor.
Using the OncoPlex diagnostic profile makes me a better doctor. It makes me more thoughtful about the patient. It makes me more thoughtful about the biology of their disease. And it actually improves the interaction with the patient because they understand that you really care about them specifically and not just applying a random choice of a treatment to their disease.